a Puscast, a review of the infectious disease literature, this one covering the first 2 weeks of August in the year 2020. References, as always, are available at edgydoc.com. And given that there are no earth-shaking announcements, let's move on to the literature, shall we? I will note that I'm doing this in an unusual place. I'm on vacation in Sun River, Oregon, so there may be extraneous family sounds, but such is life. Not infrequently at work, I am asked about copper and whether copper is good for decreasing bacteria on surfaces. I usually shrug my shoulders, saying I'm not going to lick my pennies anytime soon. But there is an article out in Open Form Infectious Diseases that does suggest that copper impregnated surfaces do lower the microbial counts on high-touch surfaces in an acute care hospital. Copper surfaces having a mean of 25.5 colony-forming units, whereas the standard surfaces having around 60. So it more or less have the amount of bacteria found on surfaces if it was copper impregnated. Although it should be pointed out that the copper surfaces also had bacteria on them, so this is not a substitute for good hand hygiene. Also, it'd probably be very expensive. It's my understanding that copper is one of the metals that we are sort of running out of, or is becoming more expensive to mine. So it would be difficult to copper impregnate your whole hospital. But it would be an interesting way to decrease the overall amount of bacteria in your environment. And that being said, I'm still not going to lick my pennies. There have been some curious studies to suggest that probiotics may prevent some kinds of infections. I will admit that as time has gone by, I'm increasingly unenthusiastic about probiotics in general and for specific indications such as the prevention of C. difficile diarrhea. And over the years, the better the study, the decreased efficacy one finds, which probably means they don't do much. That being said, there was a study that asked the question, will giving probiotics to nursing home patients prevent or decrease the use of antibiotics? And the answer was, what a surprise, no. So added to the list of studies that show no efficacy of probiotics. And being a prior plausibility kind of guy, I can't see how taking lactobacillus and bifidobacterium would do much of anything in anybody. I have been awash in COVID articles, and it's difficult to know which ones will actually be relevant. I mean, there are lots of articles about COVID in certain subpopulations, which I no longer read. COVID in patients with inflammatory bowel disease. Can't see that's important. There was an old rule about never reading an article with an enzyme in the title. I think that now applies to subpopulations of those affected with COVID. A year from now, someone will go through all this literature and actually summarize the important ones. And these are the ones that I found at least interesting in the last 2 weeks. The first is how often do you see bloodstream infections in critically ill COVID patients? To date, I've seen one, but this study out of Italy suggests it is more common than that. They found that 1 in 4 patients developed a bloodstream infections after 15 days, and if you've been in the hospital for 30 days, it was over 50%, which is pretty impressive numbers. And these rates were higher than has been found in other studies. You have to wonder if the study coming out of Italy had more to do with their being swamped with patients, and that is why they had more than the usual bloodstream infections. I've seen far more invasive aspergillus infections than I have seen BSI so far in COVID patients. Diagnostically, how good are nucleic acid amplification tests? Looking at all the tests together, they have a sensitivity of between 82 and 97%. So average it out to 95%, and you got it more or less right. No test ever being 100%. There's also a report in the MMWR of 15 cases of methanol poisoning in people who were swallowing hand-based sanitizers in part to prevent COVID or treat COVID. I wonder who, if anyone, would recommend such nonsense in people. Certainly no one who would take responsibility for the other 165,000 deaths or so we've seen at the time of this Puscast. And a study out of the great state of Oregon, looking at seropositivity for COVID in a random population, really suggests that the number of actual cases are 10 times the number of cases diagnosed. And that's been a consistent finding across the U.S. So whatever the numbers are, it's actually probably 10 times that. And while you never get herd immunity to naturally occurring diseases that I'm aware of, it's nice to know that the United States is rapidly becoming immune, whatever that means, to COVID. Maybe I'll start to fly and go to bars again sooner than I anticipate, because right now I think it's going to be at least another year, absent a vaccine. I mean, as an ID doc, I'll be on the front line, so I'll probably be in the first group to get vaccinated, but I don't want to travel without my wife, and she'll probably be in the last group to be vaccinated. As I go on a hike every day here in the beautiful Sun River area, a tremendous number of amazing hikes. Most people are wearing masks, and when you see someone coming, you put a mask on until you pass by them. But how long is that air safe if the person I pass on the hiking trail is infected with COVID? Of course, that depends in part upon air movement in the area, and it is quite breezy up in the mountains. But this study looked at how rapidly SARS is inactivated by sunlight, and they found that takes 20 minutes to get a 90% loss of COVID using simulated fall light, and you'll get about the same in 8 minutes with summertime simulated light. So if you're outside in the summer in absolutely stagnant air, the COVID will be killed off by sunshine in about 8 minutes, at least here at Sun River. So I'm still holding my breath for a period of time as I pass people on the hiking trails. And of course, many of them are not in direct sunlight. And a trial of hydroxychloroquine for post-exposure prophylaxis of COVID-19 that was published in the New England Journal of Medicine in August shows it doesn't work. What a surprise. There are hundreds of other COVID papers out there, but those are the ones that caught my nearsighted eye. Of course, I've been waiting most of my professional career for a pandemic, but I always thought it was going to be a strain of influenza. I thought we had it with H1N1, and while it was a bad virus, it was no 1918, 1919 strain. Also been waiting for bird flu to jump into humans and rip through human society, which could really cause some mortality. Fortunately, we have somewhat of a step up against bird flu with both vaccines and medications, but there was a nice review in the Journal of Infectious Diseases, which I thought was interesting in that all bird flus are not the same. Looking at 6 different bird flus, H5N1, H7N2, H7N3, H7N4, H7N7, and H10N7, found there were differences in the epidemiology, some strains preferring to kill the young and the female. Others are more likely to be seen after visiting live poultry markets, while others it's an exposure to a sick or dead bird. So different bird flus have different epidemiologies, infect different populations of humans, and are more likely to kill different populations of humans. While I can think of a few things as disastrous as a new strain of influenza this fall to match our incompetent approach to COVID, there's always avian flu lurking in the background. And if it ever jumps to human in the way that COVID jumped into humans, boy, we're in a world of hurt. That would be a 1918-1919 level pandemic with mortality. And remember that influenza has many different adverse downstream effects. For example, patients who get influenza are much more likely to be readmitted to the hospital in the following year, both at 30 days and a year out of having a case of influenza. So influenza is bad for you. Just like influenza is an independent risk factor for a myocardial infarction. I always harp on the fact that the influenza vaccine does far more than prevent you from getting the flu. It prevents the downstream complications of influenza, which will probably be more important this fall as we get what I'm betting to be a huge increase in the number of COVID patients on top of the influenza we always see. This really could be a particularly ugly fall and winter. But hopefully I'm wrong, and it will all miraculously just go away. And remember that it is likely to be pigs from whence we get our next pandemic flu, and a nice study to show that swine workers are at marked increased risk for developing pig-related influenzas, at least to judge by their serology. A swine worker is one who works with swine, not one that is a swine. I'll throw this out there, mostly because it's a curiosity about Epstein-Barr virus, and since we can't do anything about Epstein-Barr viruses, I usually think, who cares? But this study looked at the association between EBV and bronchiectasis, and they found that patients who had EBV DNA in their sputum were more likely to have a shorter time of duration between exacerbations of their bronchiectasis and to have a greater decrease in their lung function over time, suggesting that maybe perhaps EBV is associated / causal in the bronchiectatic exacerbations of these patients. It's interesting. We'll see if it pans out with future studies, but would be more interesting if we actually had therapeutic interventions against the EBV. This is a study out of Korea where they have a lot more hepatitis B. So what they did is they took patients with hepatitis B related hepatocellular carcinoma who were getting transarterial therapy to kill off their carcinoma. And those that were placed on anti-hepatitis B therapy during this intervention did better. They had a more prolonged survival. The take-home being, if you're going to treat your hepatocellular carcinoma patients who has active hepatitis B, treat their hepatitis B as well. A couple of HIV studies. Women with HIV disease who take integrase strand transfer inhibitors have more weight gain. Pre-exposure prophylaxis in young black men who have sex with men in Atlanta, Georgia, was associated with discontinuation that was frequent and suboptimal coverage with their pre-exposure prophylaxis for HIV. This, of course, is the same part of the country that doesn't wear masks, so what the hell do you expect? Doing appropriate preventative interventions doesn't seem to be the Southern way of doing things. My career in infectious diseases started with the HIV epidemic, which I like to point out is association, not causal. And it's been quite striking in the difference in deaths over the last 30 plus years. Now, according to this study, 1 in 5 deaths in HIV patients are due to cardiovascular diseases, which, of course, do have risk factors that can be modified, such as smoking, hypertension, and lipids. I remember the old days when all my patients died in 6 months tops after an HIV diagnosis. Now they get to live to a ripe old age and die of the same disease as I will. Although my theory has always been that you die of your subspecialty, so I suppose I'm destined to die of an infectious disease, hopefully not COVID, rather than a cardiovascular disease. So many diseases that we do not have here in the great Pacific Northwest. One of them is anaplasma. It's a tick-borne illness that usually has fevers, muscle aches, low platelets, and a transaminitis. There is 4 case reports in open and form infectious diseases of patients who presented with pulmonary symptoms, and the imaging had ground glass infiltrates, i.e. it initially presents like COVID, except for the thrombocytopenia part. So those of you unfortunate enough to practice in parts of the country where there is anaplasma, remember that rarely it will present in a way that will make you think it's COVID. Resistance, of course, is making the treatment of many infections problematic, and that includes Mycoplasma genitalium. This study looked at the efficacy of other antimicrobials in this disease, and they found that pristinamycin plus doxycycline had a 75% cure rate and minocycline a 71% cure rate in organisms that are quinolone resistant and macrolide resistant. So there's an option for you if your patient has M. genitalium. You may not remember the pathophysiology of plague, but what happens when a flea consumes blood with Yersinia, the Yersinia multiplies in the foregut of the flea to cause a mass, which causes obstruction, which then, when the flea feeds again, it vomits into the skin to pass on the infection to the next human being. And there's a really nice review of this whole pathophysiology in PLOS Pathology, where if you're fascinated by pictures of a mass of goopy Yersinia in the foregut of a flea, that's your ticket. But it still remains a fascinating bit of pathophysiology for the transmission of a pathogen. I did my internal medicine residency in part at a county hospital, Hennepin County in Minnesota, and at the end of every call night, my fingers would be purple from gram stains of various bodily fluids trying to make a diagnosis. Resident labs have become, unfortunately, a thing of the past, but I still have an affinity for gram stains and the information that they give. And what a gram stain shows, or sometimes doesn't show, is an important diagnostic indicator. This review of the efficacy of the diagnosis of gram stain for community-acquired pneumonia suggests that it is very specific if you have Streptococcus pneumoniae and Haemophilus influenza as the cause of your community-acquired pneumonia. If you have a good specimen, of course. And that, I think, is often the problem with sputum gram stains, is we don't go through the effort to really have the patient honk up a good loogie for the diagnosis of the pneumonia. So add a good gram stain to your diagnostic armamentarium for pneumonia, which still remains the most frustrating infection to diagnose accurately. There have been a fair number of papers about the incidence of macrolide resistance in Mycoplasma pneumoniae, but they've all come out of Asia, predominantly Japan. The question is, what is the rate of macrolide-resistant Mycoplasma pneumoniae in the United States? And now we have an answer. 7.5% across the United States, with the prevalence higher in both the South and the East at 18%, and only 2.1% in the West, which kind of surprised me because I thought we would have imported resistant mycoplasm from Asia being closer. Although the good news, if it is good news, suggests that antibiotics make little, if any, difference in the course of hospitalized mycoplasma pneumonia. At least that's my take on the literature. This is an interesting study because I would not have believed the results. They looked at the effect of vancomycin versus metronidazole for the development of VRE, vancomycin-resistant enterococcus, and found that both drugs had the same risk associated with it, and that using oral vancomycin did not appear to drive the development of VRE. And this was in a tremendous number of patients, 86,000 plus in the VA system. And as they point out, though, for the development of resistance, the best antibiotic for preventing antimicrobial resistance is no antibiotic. But at least you can give vancomycin with some assurance that you're not breeding VRE. So I always love an article that confirms my bias, even if it is a retrospective observational study. So what it was is patients with community-acquired sepsis or septic shock who also had positive blood cultures. And they found that a single dose of an aminoglycoside, specifically gentamicin, with a beta-lactam was associated with decreased mortality and no acute kidney injury. A study that supports my bias that for sepsis/septic shock, your best antibiotics up front are a beta-lactam plus a single dose of an aminoglycoside, because I honestly think that all the efficacy of your aminoglycoside is probably with the first dose. And it does, at least in this study, decrease mortality without increasing the risk of kidney injury. Although, if there's ever been a topic that Newton's second law of the medical literature, for every study there's an equal and opposite study, holds true, it's on the aminoglycosides for sepsis literature. A couple of soft tissue infection studies, one about antibiotic duration if you have boils. After incision and drainage, 5 to 7 days or even up to days of antibiotics have better outcomes in terms of relapse, and that is independent of the size of the abscess, which doesn't surprise me, as once you IND the boil, the amount of infection left behind is probably the same. However, the big problem with this particular study is it is a subgroup analysis, and those are always questionable. And a randomized study shows that compression stockings are beneficial in preventing the recurrence of cellulitis in patients with chronic edema. I should say compression therapy, not compression stockings per se, but keeping the edema down is important in preventing recurrence of cellulitis. A bunch of endocarditis stuff, not unsurprisingly. Injection drug users with endocarditis do poorly long term, even after valve surgery, with a 10-year survival rate of 44%. They tend to die, surprise, surprise, of recurring episodes of endocarditis or other infections. Injection drug use is just not a healthy lifestyle. In part, of course, because patients often leave AMA, and there was a study that looked at the incidence of leaving the hospital AMA in injection drug users, and they tend to do it promptly within the first 3 days, and the incidence of patients with endocarditis leaving AMA has been increasing over the years, which would be no surprise to anybody who treats endocarditis patients for a living. Many a patient has gone out AMA, never to be seen again, presumptively to die of their endocarditis. I always find those cases to be particularly sad. And treating enterococcal endocarditis is probably the biggest pain because ceftriaxone is twice a day and ampicillin is 4 times a day, and 6 weeks of that is a royal pain in the neck for the patient. This study looked at whether or not you could get away with 4 weeks of therapy for enterococcal endocarditis, and the answer was yes, the big caveat being if patients had symptoms for less than a week and or they didn't have a ring abscess, you could treat them with 4 weeks of ceftriaxone and ampicillin. And the conclusion of this study is peculiar, and I do not quite know what to make of it. What happens after you publicly report your valve surgeries? Well, it was associated with, quote, a significant decrease in valve surgery for all endocarditis patients, regardless of whether or not they used injection drugs, and a reduction in in-hospital mortality for patients with endocarditis. So, publicly reporting your valve surgeries led to fewer valve surgeries and less mortality. And I don't know how to weigh that against the studies that show perhaps a better outcome in earlier surgery, at least in some subsets of patients with endocarditis. Finally, there is a review in the New England Journal of Medicine this month on native valve endocarditis. You can read it at your leisure if you like a nice review. I will point out only one thing in the article, that the duration of antibiotics for the treatment of endocarditis, well, there was no mention made that you start counting from the last negative blood culture, which, as the house staff know at my hospital, is one of my bees in the bonnet. And I think it's a waste of resources to start your duration from the last negative blood culture for any infection. And there is zero data to support that practice. Literally zero. It is not uncommon to screen for urinary tract infections prior to surgery, although the data to date suggests that it is a useless practice. Here's another study that shows it is a useless practice, although patients who were screened who had pyuria were frequently given a course of antibiotics. The only thing the antibiotics did was increase the risk of C. difficile and made no difference in the surgical outcome. The bug in the urine virtually never goes to the surgical site. Yet another study to show that you treat symptomatic urinary tract infections, and pyuria is not a symptomatic urinary tract infection, and treating it does nothing, at least in the pre-op population. And giving a quinolone to mother for their urinary tract infection increases the carriage rate of community-acquired quinolone-resistant bacteria in their children. It about doubles the risk. As I've said before, I think of people like Pigpen in Charlie Brown. We're all in a haze of bacteria and shedding cells and dirt. And whatever bacteria is in our cloud, being a quinolone-resistant E. coli or an MRSA, is transmitted to the clouds of our family members. And a review of Staph lugdunensis urinary tract infections. Staph lugdunensis, as you may not remember, is predominantly a coagulase-negative staph found in the lower extremities. It likes to live on the great toe. And when you find it in the bloodstream, it often means endocarditis. But it is also a cause of urinary tract infections. And unlike Staph saprophyticus, which is alleged to be a common cause of UTIs in young women, I say alleged because I really don't believe it. I think I've seen maybe one in 35 years. Staph saprophyticus tends to be a cause of urinary tract infections in men who've had urologic procedures and is often hospital acquired. I was always under the impression that any CNS infection was bad for you. However, this study looked at the effects of enteroviral meningitis in patients in Denmark and found that it had no impact on their health, social functioning, or long-term survival. So it appears at least that enterococcal meningitis is indeed a benign, if unpleasant, infection, unlike other viral meningitides, which often cause significant morbidity and mortality. The IDSA guidelines suggest removing the prosthetic joint if the infection develops more than 30 days after the arthroplasty. I have to admit, I've never done that. I figure everybody is worth a trial of debridement, poly-exchange, and a course of antibiotics, and I think it works more often than not. This study looked at doing exactly that for patients who have had infections in their prosthetic joints more than a month after implant, and found that if the symptoms were less than a week, that doing a poly-exchange and debridement and a course of antibiotics was reasonably effective at salvaging the joint, with a failure rate of around 38%. Numbers that are reasonably consistent with the literature and always seem a little high to me. Although this series had a remarkable number of gram-negative infections, of which I see maybe one every other year. But even considering that, I think everybody who comes in with a prosthetic joint infection deserves at least one attempt at salvage before you take out the joint. And most of the time, it works, depending, of course, on the microbiology and the host factors. An interesting editorial about why we should stop using the word leprosy because of all the stigma associated with the biblical manifestations of the disease, and that in places like Brazil, it's now officially renamed Hansen's disease. And the WHO also supports the cessation of the use of the word leprosy because of all the discrimination and stigma that occur. Never having read the Bible nor attended church, I was unaware that there is a particular stigma in the Bible associated with this disease. I would suspect that in countries where Christianity is not a predominant religion, that they still have issues of discrimination and stigma with this disease based upon its clinical presentation. And whatever you choose to call it won't change that, unfortunately. Rifampin has long been known to be a potent inhibitor of the P450 system, and it particularly likes to increase the metabolism of various steroids. It's the one that if you have a patient on birth control pills, you have to make sure, if they're also on rifampin, that they use an alternative form of contraception. And it may be true for depot-medroxyprogesterone as well. In this study out of Africa, 12% of women had subtherapeutic concentrations of medroxyprogesterone acetate, the depot stuff, when they were on rifampin and efavirenz. I have never considered depot medroxyprogesterone as an issue in the patients in whom I have on rifampin, though I often ask if they're taking birth control pills. I think I need to be more specific in the future about specifically what birth control they are using to avoid this problem. Because the last thing you want in your patients on rifampin is an unintended pregnancy. And we'll finish up with a dalvabansin article wherein patients who were in the hospital for whatever reason for the entire 6 weeks of antibiotics were instead given a dose of dalvabansin and discharged, saving the last week of antibiotic therapy from needing to be inpatient, saving an estimated $9,600 per patient because they weren't in-house that final week. Of course, I always wonder if they actually needed that final week of therapy. It's the same issue I have with the oral treatment of endocarditis after a couple of weeks of IV therapy. And I wonder how many of those patients were actually a cure at the time they were switched over to oral therapy. I still bet the vast majority. I suspect if you looked at cure rates over time for many complex infections, it would not be a straight line, but an S-curve. But I've looked in the literature to see if anyone's ever done those kind of studies, and I can't say they exist. And that brings us to roughly the 30-minute point, so I will bring this Puscast to a close. A review of the infectious disease literature covering the first 2 weeks of August in the year 2020. References, including some interesting articles I didn't talk about, are available at edudoc.com, home of my multimedia empire. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you, and take it away, Jeff.